Yes, already 10 participants are. Can we start now?
Okay.
Yeah, that's okay with me.
Hello, sir.
Hi.
Hi. Shall I start?
Yeah, go ahead.
Okay. Good evening, everybody. Today we have Neurovascular Clinic. I am Dr. Vishal V. Panicker. I will be presenting the case. I am from Rajagiri Hospital, stroke fellow under Dr. Gigy Kuruttukulam, sir. And today's moderator is Dr. Kaushik Sundar. He done his PDF from Rajagiri Hospital. Presently, he is the clinical lead for stroke and neurointerventional service in Kolkata, Narayana Health Group of Hospital, and he runs his own stroke fellowship program also. Coming to our case, this is a 75-year-old gentleman who presented with right-sided weakness of grade 0 and grade 3 power in right lower limbs. He got global aphasia and last non-well was 6 hours back. He was a type 2 diabetic patient on treatment, and at presentation, his NIHS was 12. This is the clinical video. He's aphasic. He's not able to obey the commands. And there's grade 0 power on right upper limb. Lower limb, he's able to flex. And patient was taken up for MRI. And this is the diffusion weighted imaging. You can see there is an involvement of the caudate nucleus and lentiform nucleus, and there's lentiform insular cortex also involvement, and there is the M2 segment of the operculum is also involved. So his diffusion weighted aspects comes around 6. And this is the flare scan, which also shows similar changes in the caudate, lentiform nucleus, insular cortex, and the opercular region. And this is the SW imaging. Didn't show any hemorrhagic changes. So, and this is the MR angiogram picture showing the right internal carotid artery is intact with the this is the MCA branches and ACA, and the left side we can see there is no internal carotid artery visible, and the distal branches of the MC is also distal, and the proximal branches are also not visible. And here we can see the internal carotid artery is almost completely stenosed with a streak of flow through the proximal segment of the internal carotid artery. So we took him for mechanical thrombectomy and through the right femoral route. And this is the first shoot of the right internal carotid artery shoot showing the normal MCA and the ACA, and the right ACA and left ACA also filling through the right internal carotid artery, but there is no A1 segment visualized. And this is the lateral view. And the left common carotid artery shoot showing the internal carotid artery is not visible at the proximal part. The distally we can see from the cavernous segment onward, there is some streaks of flow, contrast filling can be seen, but the M1 and the MC and the AC is not at all visible, and the distal carotid alone is visible. So this is another view, which also showing the petrous part and the cavernous segment is filling, and there is no flow from the distal carotids. And this image showing the proximal carotid complete occlusion. There is no flow across the carotid, showing a flame-like occlusion in the proximal carotid. So by navigating, we had little difficulty to navigate the microcatheter and microwire across. But after a few try, the microwire go beyond the proximal segment, and with the microwire and microcatheter technique, and the neuron max was placed in the common carotid artery. And after the microwire negotiated the proximal segment, we took a balloon, this 3.5 into 12 balloon, and we dilated the proximal internal carotid artery segment. And after a few dilatation, and while dilating, and we bring the neuron max to the proximal segment of the balloon, and over the balloon, we took the neuron max beyond the proximal segment, and now the neuron max is in the petrous, around the cervical segment, near the petrous segment. So through the neuron max, the shoot showed there is a occlusion at the distal portion of the internal carotid artery, and there is no flow to the MC or AC territory. So we have a distal IC occlusion with the proximal internal carotid artery. So we have the tandem occlusion, and then we took react and microwire and microcatheter together, and we were able to negotiate the react here, and then after negotiating with the microcatheter and microwire, we are able to take the react up to the terminal ICA, and we tried a aspiration alone adapt technique, and we got the opening of the distal ICA, and the ACA and the proximal part of the M1 flow was attained, and the distal M1 was occluded still, but there is a collateral spilling from the ACA to the MCA territory. We can clearly see here. And this is a lateral view. Here also we can see the ACA is spilling to the MCA territory here in the distal part. So even after one more try with the Sophia for aspiration, the M1 was still occluded, and we take the microwire and microcatheter across the clot, and this is a micro catheter shoot we took. After that, we deployed the stent retriever beyond the clot, and this is a stent retriever you can see, and advance the Sophia plus towards the clot, proximal part of the clot, and using Solumbra technique, we tried a Solumbra technique, and clot was retrieved. And this is the final angiogram after the Solumbra technique. We could achieve a TK3 recanalization. And this is the proximal part of the carotid after thrombectomy. There is some stenosis, residual stenosis, but not so bad. So we left the patient without stenting. And this is the CT after 24 hours. And there is not much bleed. And the same areas, that is the caudate nucleus, lentiform nucleus, and the insular cortex and the M2 segments are involved here also. No other areas are involved. And patients improved dramatically. Is able to obey the commands. Power completely improved. Is able to walk normally. Hello, sir.
Such a fantastic case, Dr. Vishal. So I think the results were very good. So let's start with some simple discussion. You're able to hear
Yes,
me,
sir.
right?
Yes, sir.
Okay.
I can see.
Let's go to the first slide now.
Okay, sir.
No, I don't have. Okay. So the first question that we'll start with. Okay, he is a a patient who's right-sided weakness, grade 0 in upper limb, grade 3 in lower limbs, global aphasia, NIHSS 12. Last seen at
6 hours back.
The first question that we need to ask ourselves is, what is the imaging of choice in these patients? Would we like an MRI or would we like a CT? So first thing that we need to know, like if you ask me, and
Yes,
if it was me, so the first thing that I would like to know in this patient is whether it's a bleed or not.
Yes.
Correct?
Yeah.
To your luck, you had a patient who was otherwise following so many commands. I saw that video. Not necessarily he had a aphasia, agreed, global aphasia, but I think he was a little stable for your SWI or MRI and all that. It's probably a 30-40 minutes procedure, including the scan, shifting, and everything. So whereas a CT would have given you much more answers, is what I felt. But that's okay. That's okay with me. So you do a CT, you take off the possibility that it could be a bleed. Then you see, we have not, obviously we don't know what's the aspects. But in this case, I would have told CT angio was important. So I will ask you one question, Dr. Vishal. So now that you know the case end to end, okay, what do you think happened to this patient? Is it a tandem occlusion? Is it a distal T occlusion? Was it a carotid stenosis with an distal occlusion? What exactly do you think happened in this patient?
There's a
Could this be an embolic stroke from the heart?
artery to artery embolism from the carotid stenosis. Must be a clot.
What if it was a chronic carotid artery occlusion? You're getting what I'm saying, right?
Yes, yes.
How do you differentiate that?
Oh.
See, there are two, three possibilities here. Okay.
Yes, sir.
One, this entire thing could be an embolic phenomenon.
Yes.
There is a clot that goes from the heart, goes into the distal T. We have seen this so many times where even if there is a distal T occlusion, the carotid starts not filling up from the neck.
Okay.
Correct? You have seen that. You have seen that flame shape. And if you look into your MR imaging, I think, can you go to the MR angiogram? Yeah, okay. I'm sorry. Yeah. Okay, next one. Yeah. So you could see something faintly coming from the carotid.
Yes, sir.
Correct? So
yes.
Now there are so many questions that are coming into your mind. Remember that you are fighting with time right now. Okay.
Yes.
So the first thing that you want to know is it going to be an embolic stroke or not? Because you need to understand what kind of hardware to take. Am I going to use a balloon? Am I going to use a stent or something to cross that lesion? Or I'm going to use a large bore aspiration catheter system to aspirate my clots from the carotid. Correct? Now,
Yes.
when you have a carotid artery, what is the normal size of stents that we use? 6-840, correct?
6-840.
Exact acculink. So your minimum carotid diameter is what? At least 5 to 6 millimeters. Now, if you are going to use a react, and you're going to aspirate a large clot or against a stent retriever of 4/20. So obviously you need to know, not all your clots are going to get sucked. Correct? So the first thing that I would like to know is, what am I dealing with? Am I dealing with an acute carotid artery occlusion, probably due to a distal, an embolic source that went from the heart, and then it occluded the T, and I'm not able to see the proximal carotid? Or I'm dealing with a chronic carotid artery lesion? Then the next question that I need to ask myself is, if it is a chronic carotid artery lesion, is this a chronic carotid occlusion or a chronic carotid stenosis? You're getting what I'm saying? So there are two possibilities. Either this is an acute lesion or it's a chronic lesion. If it is an acute lesion, okay, that's fine. If it is a chronic lesion, is it a stenosis or it is an occlusion? How will you be able to make that out? You're getting what I'm saying, right? Because your hardware is going to change.
Okay.
Supposing if you're going with a distal T occlusion, then you're going to say, okay, I'm going to take a Neuron Max or whatever distal. I'm just going to take React and a large bore system. I might use a stent retriever to track it up, but I'm just going to aspirate the whole thing and come back. Okay. But if you're dealing with a chronic lesion like carotid, then you're going to say, okay, this is going to be difficult. I'll have to take a cross flow. I'll have to check how the collaterals are. Maybe I'll have to think of a balloon. So I will take a Neuron Max, go and take a balloon on my table, keep it ready. If required, I might reach a larger balloon, go in, then see what's happening. Correct?
Okay.
How are you going to assess that? Remember, you're seeing this patient first time in the emergency room, and all you have done is you have done a brain imaging. How are you going to assess? See, what I'm trying to prepare you is, I'm trying to prepare you based whatever individual experience that I have had to decide the hardware. And remember, hardware comes at a price. Maybe you have good aux materials that you can keep, but hardware comes at a price, and you need to decide what you're going to do inside. Okay, so let us come back to something. Why I felt that CT angio would be very helpful for this patient. Okay, so the first thing is we did the CT. CT is not showing any bleed. Now the CT angio will help me in so many ways. The first thing that it helps me is to identify collaterals. Correct? Yes. Now in this MRI, you are not able to see the collaterals which you saw in your DSA. Correct? Yes. So thankfully in CT angio, we have a phase called delayed phase or a venous phase where you can assess the collaterals. Correct? Yes. What will collaterals tell you?
If there is good collaterals,
what does it tell you?
It will tell you it is a chronic process.
Exactly. So first thing that gives you some confidence. Now, is there any indirect telltale evidence in your MRI to say that this collaterals are there? Can you show me that MRI diffusion weighted images? You are dealing with a huge carotid artery lesion, correct?
Yes.
Look at the size of infarcts.
Infarcts are small.
Even the MCA is not completely involved. Okay. What you are seeing is only the perforators and one division probably.
Yes.
Correct? So if you look at it like a collaterals from the ACA and PCA, let us say leptomeningeal collaterals, you are already seeing those so-called watershed areas completely free.
Okay. Yes.
6 hours. Imagine if you had a cardioembolic stroke, you would have seen these T occlusions, cardioembolic. How many you would have seen? They will all be present in a very bad state.
Bad state.
Correct? You don't have the time. You know, they might come even in 2 hours. You won't have the time. But look at this MRI. This is very surprising to me. See, even the diffusion restriction is different between the subcortical and the cortical areas.
Yes.
Okay. So this gives you an indirect evidence that this is chronic. Meaning, I'm not saying that this is a chronic occlusion. Please understand this. What I'm trying to tell you is there is some chronic insult, vascular insult that is happening to the left side of the brain, which the patient is maintaining over time. Okay. That is what it is telling you, right? So this is my first thought that I am thinking of. Okay. Of course, the caveat to this rule is that if at all your thrombus is RBC rich, then you could have a similar picture. Again, how will you know this difference? Of course, one is when you retrieve the clot. Before you retrieve the clot, can you make out this difference?
From CT, we can see hyperdense
sign. So if there's a hyperdense sign, then you know possibly that we are dealing with an RBC rich clot. Okay. Correct? And so this gives you some more information. So you're processing. Imagine your mind should start working. Okay. The other reason why we need CT angio is, now that I know that the collaterals are good, that means it is telling me that I am dealing with a chronic lesion. If it is a chronic lesion, was it a stenotic segment that got occluded or it was a chronic occlusion? How do we know that in CT angiogram? See, supposing you have a 95% stenosis, then also you will develop good collaterals like leptomeningeal and all that. You will also develop good collaterals if you have a chronic total occlusion. Okay. Correct? What will tell you the difference? How will a CT angio differentiate these two?
There is complete.
So, sorry,
There is
go ahead.
complete occlusion of the.
See, the complete occlusion is MRI has shown it. There is no
in CT angio.
So Dr. Singh wants to say calcification. That's a very fantastic point. Calcification again tells you whether it's a chronic lesion or not. Agreed. Totally agreed. You have a carotid that is calcified. And I would suggest that, we can unmute and talk among ourselves, meaning it's just like a small class, hardly 10 people. I don't think we'll disturb each other. So if there is a carotid calcification, again, it tells you that it is chronic. But is there anything that tells you to differentiate a stenotic segment that got occluded whereas a chronic total occlusion? Are you able to understand what I'm trying to tell? A 95% stenosis patient where you had an occlusion, or a chronic total occlusion and then the patient has had another stroke. This is very important. Think about it now, Dr. Panicker. If there is a chronic total occlusion, where is the source of emboli? You're getting what I'm saying? If there's a chronic total occlusion, where is the source of emboli? That is a major thing that we ask of, because there is no forward flow.
No forward flow, yes.
So where did the emboli come from? Okay, so I'm just thinking like that. Okay, so it could have come from the other side. You could have had a right carotid artery stenosis that was causing some lesion. I'm just giving you theories.
Okay.
So if it is not, then this is an stenotic segment which got acutely occluded and one more thrombus went up. That is the other theory. How do you differentiate the two?
The opposite side will be involved in case.
In what? No, I'm talking about if you have a carotid lesion. Now you have established it is chronic. Your collaterals are good. Your MRI is showing good evidence of mismatch, and you know that okay, there is some amount of leptomeningeal collaterals that are working very fine for this patient. Correct? Now you know it is chronic. My only question to you is this a chronic stenotic segment that got occluded now, or it is a chronic total occlusion?
Chronic stenotic process get occluded now.
How do we know?
Because there is a thromboembolism happened. So
okay, that is one way. We are theorizing that. So there has to be a forward flow, otherwise it will not have carried out. Why will a right come all the way across all your AC and go that side with no evidence of infarction on the right hemisphere, posterior? You don't know. So agreed, that is one point. Is there any other evidence that you can use to say that this is a chronic total occlusion, meaning chronic stenosis that has got occluded now? Again, CT angio helps in these cases. Sorry?
Nothing. Okay.
No, if you have to tell Panicker. No issues.
AC artery is not involved here. So
AC is anyways good collaterals are there. Meaning good cross flow is there.
Maybe. Okay.
Good cross flow is there. So the one thing that we see is called a hot carotid sign or a carotid ring sign. Okay. So whenever the contrast is being given for carotid lesions, if you have contrast enhancement across the vessel wall, that indicates there's an acute thrombotic occlusion. If there is no enhancement of the vessel wall, that it indicates it's a chronic occlusion. Now, this may not be true always, but a good chunk of time we have seen that. So we do a CT angio. When the CT angio is there, you look at the carotid cuts. You're not able to see them in the axial. But in the axial carotid wall, if you are able to see an enhancement, then it is called carotid ring sign. There are a lot of papers on that. Sadly, that has not been given a lot of importance when you are looking at it. So when you see a carotid ring sign, that tells you, boss, this is an acute, there is a chronic stenosis with acute occlusion, and then there is a tandem lesion that has gone in. Okay, so this is very important. This gives me an idea. Why this is important is, I need to know how am I going to go in to open this vessel. Okay. Now, sometimes in a chronic total occlusion, that is very, how do I say, very, very tight. You might have to use even a thermo to cross the lesion. And you do not know how the end is. In your case, there was another advantage, I'll tell you. Okay. Whereas in a stenotic segment that got acutely occluded, you still have some space to maneuver. It gives you an idea. Now, am I going to cross this lesion with a hybrid, or am I going to cross this lesion with a thermo? A tight chronic occlusion, you might have to sometimes probe your neuron max through it, keep it there. you're doing very
Yes,
rough
sir.
work. You've seen that.
Okay.
I'm sure you
Yes.
would have seen that. Whereas in acute lesion, like for example, you have a T junction lesion, and then the clot is extending all the way down. You just pass a microwire, it will just go.
Okay.
Okay. So this was the question that we need to ask ourselves. So this gives you an idea. So the first imaging of choice in this patient, especially because it is 6 hours, I would have thought of a CT angio first, because the simplicity of doing it for assessment of collaterals, and also it will give me an idea whether it is an a chronic occlusion or a chronic stenotic segment. Okay. Agreed with this point? Okay. Now we have done your MRI. You have put your aspects. Please go on forward. Come back. I have not missed any slides, right?
Yes, yes.
Okay. Next. I'm not going into all this. Okay. Very good. Okay. 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 Next slide. Yeah, you have done a femoral puncture. Next slide. Oh, okay. Now, I would have loved to see a little more run of this. My guess is, if this image you had allowed it as a video to run, I am expecting the left ACA's collaterals, leptomeningeal collaterals would have come down all the way to the right. Sorry, all the way to the MCA territory. Are you able to understand? From the left
Yes.
ACA, the leptomeningeal collaterals would have all the way come. Why am I saying that? When you had opened up the vessel where M1 was still occluded, we could still see that collaterals coming up.
Yes.
Agreed? Okay.
Yes.
So that is one thing that I would have seen. But what I'm not seeing is, after the ACA on the left side, there is no formation of MCA and distal ICA. Why do you think that happened? You know this is an MCA occlusion. Apart
Yes.
from the carotid, the tandem lesion is MCA. Why? Because you have only MCA territory infarcts.
MCA territory.
Correct? So there
Yes,
should
sir.
be a good cross flow that you expect. Why do you think there was no cross flow from right to left? One, probably this is just a still image. Maybe if you had taken a forceful injection with a video, we would have seen some cross flow. Can you tell me 2 other reasons why we are not seeing this cross flow
Absent
across?
A1. Absent A1.
Absent
segment.
A1. So you have a hypoplastic ACA that is not causing it. What is the other possibility?
Occlusion at the thrombus.
Occlusion at the?
TOP.
Okay, you are saying it's a T junction occlusion.
T junction.
Okay, agreed. But T junction occlusion, okay. Any other possibility?
Good PCOM.
Dr. Jayasankar, please go ahead. What do you mean by those PCOMs? It's very important. I want Dr. Panicker also to understand this point.
Because if a good PCOM is there, there will be enough pressure to prevent.
So there is be a contrast runoff, meaning your normal blood flow is anyways coming from there, and that is why you are not getting it across. Are you getting what I'm saying? This is what Dr. Jayasankar is trying to tell. So there are 3 possibilities, One is a hypoplastic A1, or the second possibility, as you told, it could be a T. But in T now, you will see the cutoff very clearly. It won't be like this.
Okay.
And then the third point is that, like what Dr. Jayasankar told us, that probably the distal ICA is being reformed anyways, either through circle of Willis or through something else. And we'll see that in the next slide. Okay, so you demonstrated this, you have seen this, but I would have loved to see that collaterals coming from the left ACA all the way down. Collaterals is a fantastic idea of how long the patient has been subjected to an insult. An embolic stroke is a very good stroke for you to, aspirate and everything. But for a clinical outcome, a chronic lesion is also good because you have good collaterals that are coming up. Okay, this is what we see, because I have seen embolic strokes which have come within 1 hour and still doing very badly. And I have seen patients who have come so late with a chronic lesion and then still doing good, as much as 24 hours, in your institute. So collaterals play a very vital role. So the moment I see collaterals, now I'm a little more relaxed. I say, okay, this case will not turn out to be too bad. Okay, because otherwise for an IC occlusion, left, that to dominant hemisphere, your heart is already beating. And it's a tandem lesion, you don't know whether to stent, balloon, so many things. But when I see the collaterals, now I'm a little more relaxed. Okay, it's okay. It's not that bad. Fine. Can you go to the next slide? Yes. This is probably one of the most important slides here. What you are seeing here is a common carotid run, and the common carotid run is showing evidence of your left distal ICA forming up. Am I right?
Yes. Yes.
How is it forming? From which segment it is forming?
From the distal proximal cavernous segment, the distal petrous segment.
Okay. Let us come one by one.
Okay.
Go to the lateral. Yeah, keep your arrow on the lateral. Okay. Can you show
Okay.
me the ophthalmic artery?
Yes.
So this is your ophthalmic artery, correct? So
Yes.
this just below the ophthalmic artery is your carotid siphon.
Okay.
And below that carotid siphon and the cavernous whatever, all the way down is your petrous segment.
Petrous.
Correct. So you
Yes.
can say I'm not able to see the run, but you're able to see the petrous, cavernous, all that filling up. Okay. How is it filling?
Mostly through the ophthalmic artery. It's filling retrogradely.
Okay, so you're thinking that it is an ophthalmic artery that is filling it up. Okay, but is there any other artery that is giving a good amount of collaterals? Can you see it in the AP view? Okay, can you still get thin streak of straight artery coming all the way from the mouth? Yeah, what is that?
Internal carotid artery.
No, that's not the internal carotid. Where is it originating from? What is that artery?
Okay, ascending.
Ascending what?
Ascending.
Yes, Dr. Vishnuvardhan is saying ascending pharyngeal artery.
Pharyngeal artery.
Okay, so you have an ascending pharyngeal artery that is forming. What other things you can, if you zoom in, you can see those collaterals coming out.
Okay.
You have your maxillary artery supplies that are forming. So these are important collaterals. Have you heard of the Vidian arteries, foramen rotundum arteries, artery of foramen rotundum? You should know these arteries. And these arteries are forming because these are all canals that are very close. You have heard of foramen rotundum, foramen spinosum, foramen ovale, all those areas you have arteries that are coming, correct? So your ascending pharyngeal artery, your maxillary artery, and whatever your ophthalmic artery for your convenience, we will take that also inside, is all forming your, what do you call it, your, can you show me your maxillary artery?
This is the internal maxillary artery.
Can you show me your middle meningeal artery here?
Yes, middle meningeal artery is the first branch. This one.
Is that the one?
Actually, it is not
middle meningeal artery and then accessory meningeal artery.
Accessory. Okay.
Okay. So I'm just trying to see what are those. So your ophthalmic artery. So we talk about MMA embolization. We talk about the ophthalmic connections and all that. But I'm not seeing those as much as what I'm seeing at the ascending pharyngeal artery and the Vidian artery branches. But most importantly, that I wanted to tell you was look at that run. As your ECA is filling up distally, your ICA is also being so well formed.
Okay.
So well formed. What does it tell you? And that too, where it tells you more distally. Again, it tells you this is a chronic lesion.
Chronic.
Okay, so it is giving you another idea that this is a chronic. We don't know whether it's an occlusion or stenosis, but for all practical purposes, we know it's a chronic insult because the collaterals are so well formed, and that is why we are seeing it.
Okay.
The caveat to this is the other side of the coin. How many carotid lesions do you see with patients actually complaining of visual symptoms? You would have seen chronic carotid occlusion so many times. And we have read from our MBBS days, there is something called Amaurosis fugax AO. This patient did not have any vision symptom to start with.
Yes.
And how many carotids we have seen time and again? You're getting what I'm saying. So the collateral system between ECA and ICA anastom, the system is actually really very good. It's extremely good. It's extremely good. And this gives you an idea of how the brain kind of, overcompensates for occlusion that have been there for a very long time. Okay. Just give me a second. I'm so sorry. So sorry, man. Yeah. Okay. So coming back to this. So this tells you that this is a chronic lesion. See, remember this, huh? You don't have time to analyze so much. You're still thinking what to do. You're going like that. So sometimes when you're allowing this angiogram to run, then not only will the contrast move distally in the carotid ICA, it will also come down to the proximal segment to give you an idea of where the clot is. This is a classical tandem lesion. You're getting what I'm saying? This is a classical tandem lesion because when you're taking a carotid shoot, beyond the IC you cannot see.
Yes.
Correct? But in this case, what is happening? The collaterals are showing you where those two lesions are. One distally at the MCA or distal ICA, and there is one at the proximal also, because beyond which the collaterals are not. Now, this gives you an idea of how much thrombus load you are going to deal with. Okay. Can you go to the next slide? See, can you see that now? I think you are able to see those carotids coming all the way down, and possibly there is a thrombus over there somewhere. I can't see. Anyways, so this gives you an idea. Okay, next slide.
Lateral.
Yeah. So now you have seen that there is a carotid lesion there, and then you are going ahead. How did you cross this lesion?
With the microwire and microcatheter.
Correct. So now you know it's a chronic lesion. Whatever said and done, this is going to look very ugly. There is a very good chance that either it could be a very tight stenosis that had two occlusions, or it could be a chronic total occlusion. A CT angio would have given you an idea whether that hot sign is telling you that or not. Now, based on that, you will have to decide how aggressive or how passive you want to be. But what else, Dr. Panicker, is going to be your thought at this time?
And it video.
What else will you think? Very, now categorically, what am I thinking? You have two lesions.
How to cross.
You have two lesions. Which is going to be your priority?
The M1.
Exactly.
Distal.
Exactly. So your distal is going to be the priority. Why? Because you know that the collaterals have been there for a long time. This carotid has been there for donkey years. As long as I open the M1, I should be fine. Which means you should accelerate this process of just opening up the carotid. Forget about whether it is going to close again, whether it is going to do something again. I'm not worried because my ECA, ICA collaterals are good. My leptomeningeal collaterals are good. I want the MCA to be open. So my idea about this ICA is I just need a path for me to reach the MCA. That's all I need. I don't need anything else. Correct? Which means a plasty, balloon, anything. In this case, stenting is out. At least for now, I'm not thinking of carotid stenting. I'm not worried about that. Okay. So you went in. Now you are going to have a problem. The first problem that you're going to face would be that how are you going to cross that lesion? And if it is a chronic total occlusions, the problem is the clot content will be so high that even with microwire, you won't be able to cross. In some cases, what we do is we do some drilling or boring with thermo, allow the thermo to go a little up. What will happen if you dissect this artery with a thermo when you're going blindly?
Pseudoaneurysm formation.
Pseudoaneurysm is unlikely. If you dissect it, is it a problem?
Already it is completely occluded.
Exactly. Not only occluded, already it is chronically stenosis. So always think like that. Okay, if this is going to be a dissection, if there is going to be a problem over there, see, carotid rupture, pseudoaneurysms coming in, that's all we can take it lately. My biggest worry is what if I dissect this artery? What if I do something where, so your idea is get an access first. Your idea is to go to MCA as much. So if you're going with a thermo, going blindly sometimes because you want to hit through a chronic total occlusion, I still feel that that is well within your therapeutic judgments. Because you know that this is a diseased artery and you know there is an alternate conduit that is supplying. The reason why the patient is symptomatic to you is the distal, M1 occlusion, correct? So as long as you have that how do I say that, psych in mind, then you can pass your carotids, because unless you have a strong support, your other catheter system is not going to track.
Okay.
What did you did is you did slightly different. What you did was you took a microwire, crossed the lesion, used a balloon to
Dilate.
inflate and deflate, correct? Sometimes even your microwire doesn't go. So you need to approximate your neuron max or whatever against that area where it is flame shaped. And then without curving your microwire, sometimes you might use even a coronary wire, slightly stiffer wires to cross the lesion. A very small microwire like hybrid will never cross. You getting what I'm saying?
Yes.
So you need to have a slightly stiffer wire to cross that lesion. Okay. So you crossed it, you did a balloon angioplasty, fantastic decision. The moment you did your plasty, you took your guiding catheter up. Am I right?
Yes, sir. Yes, sir.
Can you show the next? Is this a video? No, right here. Okay, can you show this? Yeah, so this is your wire. You see how your wire is going?
Yes.
You see that? This tells you how difficult it is for it to go further and further.
Yes.
And then it moved. Now tell me, with this idea, what I am seeing is, this was probably a stenotic segment where you were able to navigate it through the thrombotic area there. That is what it tells me. I said, okay, now I know what it is. It has gone through that. It is probably a chronic stenosis. Then you did a balloon, 3/7/5. Okay, next.
Balloon.
Okay, you did an plasty. Okay.
Then try to move the guide up.
Yes, you used that as a support and you used the guiding. You used a neuron mask or a ballast. Is that right?
Neuron max.
Okay, you took that up. Okay, then
The neuron max gone up.
okay.
Then the shoot through the guide, showing a occlusion, distal occlusion.
Okay. Okay. Do you have a run of that? No, you don't have, right?
No.
Okay, go ahead. Then what did you do?
Then take the React microwire and microcatheter and reach the distal ICA segment.
Okay.
And done actually Sophia plus and then aspiration.
Did you use a React or you used a Sophia? Or you used
sorry,
both?
Sophia plus.
You used Sophia only. Okay.
Oh. After the first aspiration, this was the.
See, you are seeing the collaterals that are coming now from the
Yes.
ACA. That tells you that this has been there chronic. Okay. Can you play that run again?
Yes.
Stop. Do you have the run of the common carotids before?
Common carotid, no, sir. Patient was.
Because I wanted to see.
No.
I wanted to see how your distal IC was forming. Could you have seen the clot? See, what happens is, what is the theory? The theory is that we are probably dealing with a chronic stenosis that got occluded now. So when you passed your microwire, initially you saw it moving like this and then suddenly it went up. There could be a possibility that one more clot went up. So I wanted to know whether inadvertently the first aspiration that you did was actually the carotid that was proximally occluded, the thrombus from there that went up. I'm just thinking. Okay.
Okay, sir.
Now you are able to see your ACA very well. Am I right?
Yes. Yes.
So our theory of hypoplastic ACA is no longer there.
Yes.
So either it is from forward back or you are probably dealing with a T. Okay.
Yeah.
Then next what happened?
It's the lateral.
Can you go back for a second? Yeah. Can you play that? Stop. So your thrombus could probably be still sitting on your PCOM. I'm just assuming, the PCOM The first part of the fecum just after the infundibulum looks a little, yeah. I don't know whether it is just a visual that I'm seeing. Okay, anyways. When you are doing strokes, you look at everything as thrombus. So okay, then next.
MCS forming.
Go to the next slide.
This after two aspiration, then the microcatheter shoot after crossing the thrombus, and stent retriever was in sheet.
Okay. Lovely result. Can you tell me though this? Okay, so the question is, can we not waste time in plasty and directly take the neuron max up to the proximal ICA? That's a very interesting question. The only issue with that question is we do not know how tight that stenosis was and what was the plaque like. So sometimes what happens is if it's a soft plaque with say 80% stenosis, maybe your thermo will still be able to help your neuron max up. But if it is a very hard plaque with calcifications and all that, at least a minimum plasty will be required to take the neuron max up. That is an idea people take. Sometimes when we are not able to differentiate an acute and chronic, they do that. They assume that your carotid is occluded all the way from below. So they take the neuron max up slightly inside the ICA and then they start aspirating. And as they are aspirating, they push it up. So they do that. It's not a bad idea, but when you are dealing with chronic occlusions, I don't know whether neuron max will easily track up. If it tracks, well and good, yes, I agree with that fact. But it helps most when you have a T junction occlusion. Like, you don't have collaterals, you have a AF patient that you're seeing, and then you're not seeing the carotid filling up. Then I would think that it is a T junction occlusion because it's an embolic stroke. So whatever clots that are there in the proximal carotid should be soft. Go with the neuron max, aspirate with the neuron max itself. Because carotid is almost like a vessel without branches till it reaches end, you should be able to aspirate a good chunk of clot. You can do that. But in chronic occlusions, be prepared to do a plasty. That is what I would say. Coming back to this MCA, Dr. Vishal, you did see this patient having a distal ICA occlusion, So,
Yes.
of course, the ACA is being filled from right side. That is why you are not getting an ACA territory, in fact.
Okay.
In MCA, why the entire thing was not involved, that is also because of the collaterals, correct? But did you see the divisions that are involved? Your superior division, because of your leptomeningeal collaterals, had good amount of supply compared to that of the lower divisions, is what I feel. That is why you are getting, and your M1 occlusion, the proximal part, is starting to develop. You're getting what I'm saying? So this is one area of the perforators area which you would not have been able to save unless you had done an MT. So this was a fantastic decision to open up the vessel, but I think the collaterals is what saved the distal MCA part. Okay, and yeah, can you play this? Is this run playable?
So
no.
Sorry,
Okay. No problem. Okay, then the next part. Can you show me the carotid? Yeah. So now what you are seeing lower down, and to some extent, if you see, this is a very long segment diseased carotid artery. You see that?
Yes, sir.
Almost from there. Yeah. So 2-3 things are coming to my mind. First thing that comes to my mind is, I cannot stent this. And honestly, I don't need to stent it because I know that my collaterals are good. My ECA is taking care. My ACA is now, probably going to come from the opposite side. My leptomeningeal collaterals are good. I don't need it. One. Second is you are already opening up a vessel that has MRI showed influx. Correct. So I don't want a reperfusion injury. Definitely, I don't want a reperfusion injury. So if he has been surviving with a very tight stenosis for a very long time. All I need to do is just open up the M1 and leave. And how am I going to stent this long segment? I'll have to use telescoping stents that keep coming down. So I have a feeling that this is a very good decision that you made of not stenting this carotid. And that is the crux of the takeaway message today, because you and I'm telling you not based on wisdom. It's also because of cases where we have burnt our fingers by trying to stent this. Either we have had thrombotic occlusions, or we have had massive reperfusion injuries, and then we had to take them up for OT, and you cannot do anything to the antiplatelets because surgeons want it out. And then you retrospectively think maybe we could have just left it like that. So that I feel is a fantastic decision. When we are looking at an angiogram, you are not looking at angiogram perfection. That is the difference I would suggest between peripheral interventional work and what we do at neuro. As long as there is a collaterals are good, and to some extent the brain is being able to manage, it's okay to see some stenotic lesions. It is okay to see that. Meaning, we don't need to get offended by that. Or angiographically acha nahi lag raha. It's not required, because he has been living with this disease for quite some time. So I think I think Gigy sir only told this to us. Better is the enemy of good, or best is the enemy of better, something like that. Because you want the best result or a better result, and you try to achieve that, and you end up actually having a complication. A good result is good. You don't need to better it. So I think that clinical acumen, especially because if you had been, if you had done a CT angio, you would have known the collaterals. You would have seen a hot carotid sign or a carotid ring sign. You have assessed the collaterals now through ECA, ICA. You have seen the right to left flow. You have seen the entire thing coming up all the way from the leptomeningeal collaterals. You have opened up the MCA. You know your infarct is there. It's not too big. It's not too small. It's a fantastic decision to leave the carotid just like that. Even if this carotid comes back to a 99% stenosis, I am assuming as long as your ECA, ICA collaterals are taking, and your, because the vulnerable area that we are seeing in the MRI has already been infarcted to some extent. You're getting what I'm saying, except probably the major area that you saved in this case was probably the perforator area. Rest of the areas, and that is the reason why he improved so well. That is the reason why he improved so well. So I think it was a fantastic decision of not stenting the carotid, and I'm very, very happy with the result.
Thank you, sir.
Anything else? Anybody else has any doubts? I would love to answer.
Sir, how much usually we want to do plastic, like 3 mm, 4 mm, like that?
I think 3.5 is good enough for your neuron max to cross. 3.5 to 3.75 is good enough to cross. But it's not about the size of the balloon. Sometimes the larger the size gives you better, how do I say, larger the size gives you better radial force for you to open up the vessel. So sometimes when you're using coronary, so in these cases, that's what I said, like, this is a case where I just want to take my neuron max up. So I do a balloon plasty. I know my vessel is opening up. I won't even lose a minute. I'll just keep pushing the balloon further up, give a traction, put my neuron max up. I'll keep going up. Because for me, this carotid, even if it's dissected or it is deceased, it doesn't matter. I just need to go up. After that, I'll come back down and deal with it. So as long as you're able, anything that, 3.75, 3.5, you take a balloon. The idea is these lesions close up very quick. If it is a chronic lesion, it will just collapse very quick. So don't waste time. Plasty, in the same sitting itself, take the balloon up, use a traction and track it up. Like, don't take your balloon outside, take a thermo again inside, cross it, or wait to see what is happening. All that you don't have to do. If you get an opening, just keep pushing your neuron max up. I hope I am able to answer that.
Yes, sir.
Dr. Vishal,
Yes,
maybe you can go back to this MR angiogram when you're going back to hospital tomorrow for this patient, and look into those axial cuts and see if there are any thrombus that you can identify within the carotid. You know, whether
Okay.
meaning I'm not sure whether we will be, can we reproduce this hot carotid sign on MRI? That's the question. Is there a difference between a acute thrombus and a chronic thrombus on MRI? Can we see that? I don't know the answer to the question. I'm
Okay.
not meaning I will ask my guys as well, but that will give you an idea of this thing. But I think you still did a very good job with the case. But the only thing is maybe I would have started it differently. But everything else, step by step, I would have done the same thing. Except the CT angio, which I would have started with. I think every other step I would have done that.
Sir, what is the difference between the chronic total occlusion versus chronic carotid stenosis?
The chronic carotid stenosis means that you have something like a 70-80% or a 90% stenosis, you know, where you still have some space that goes in, so it becomes an ideal case for you to open the vessel up. A chronic total occlusion is that patient has occluded
100%.
segments for a very long time. Now, it's very rare for you to see a CTO. See, in other words, I'll tell it like this. Supposing if you see a hot carotid sign, you know, or a carotid ridge sign, my understanding is that the stenosis is around 70-80% or 90%, you know, still you could pass your materials up. If you're not seeing it, then there's a very good chance that this is going to be a very dirty carotid. You might have to push your thermo and do some maneuvers and go in. That's going to be a tough case. You can even think about things like GA for those patients. You're getting what I'm saying? Just you'll have to start planning. Okay, this is going to be difficult for me to go. So let's plan a GA. You know, supposing if this was not like this, you're just seeing a carotid that is occluded from top to down, but your collaterals are not good. Then you know it's a distal embolic, so you're going to only aspirate. So immediately you say, you know, we will probably finish this in half an hour. So initially we don't need a GA. Maybe we can just do a conscious sedation. So it gives me an idea. So supposing if I'm going to do a plasty and I know this carotid lesion is have been chronically occluded and the collaterals are good, I'm worried about reperfusion injury. So I will say, let us do it under GA and keep the BP low for the first 24 hours so that there is no reperfusion. So it's like a Venn diagram, you know, not Venn diagram. What do you call it? It's like a map. So the moment you see start doing this, you should start planning your case. Okay, let's do it under this. These are the materials I'll require. These are the things. So it is just going beyond just saying that this is IC occlusion, tandem occlusion, M1 occlusion. You have to plan your case that moment. At that particular time, you should start planning your case. For that, these kind of re-evaluation of the case helps. You know, come back and see these cases and then say, okay, maybe I could have done this in a different way. And then that gives you an idea. Right?
Yes.
So anything else?
Shall we wind up? Jay?
Yes, sir, no more doubts.
Yeah. And I take this forum to, you know, probably invite you guys also for that Neuro hackathon that's happening next month. You know, if you don't have your duties and all, it should be fun. We're not having too many people. We are keeping the number of registrations restricted to around 40-50. I think Jayasankar is already registered, I guess. Puzzle also, I think, is coming. You can tell your friends. I think we'll be able to still accommodate 5-10 people. But the idea is to have these kind of sessions, you know, one-on-one, just understand, have a good time and then come back. Okay. Thanks guys. Thanks for the opportunity. Good night. Huh?
Thank you,
Bye-bye.
sir.